job. You do an amazing job just spreading knowledge about peritoneal surface malignancies. And I'm so glad to can speak today about PIPAC during the month of the self-awareness, of the awareness of the appendiceal cancer. And we have to keep in mind that pseudomyxoma peritonei is a rare disease, but it has always been around the world. We can find many cases from the ancient cultures, and we can see still today how this disease, how devastating it could be for patients who are not treated properly. Because we know that the gold standard for the care of pseudomyxoma peritonei is cytoreductive surgery and PIPAC. And I want to make you think, what about if there is no option for cytoreductive surgery and PIPAC? I think all of us, we have to keep in mind that this is a very aggressive surgery. And I want to show you this video from a patient. She's a graphic artist, and she made just this video just showing how she felt and during her treatment for pseudomyxoma peritonei. And basically, I think I learned a lot seeing this video, because we have to be very careful with the words that we use with our patients, like cytoreductive surgery is the mother of all surgeries, or something like this, which is very impressive for patients, or how she thought in her mind about the chemotherapy and the PIPAC and how is it going to be for her. But of course, we are very lucky if a patient can be treated by cytoreductive surgery and PIPAC, and that's the first thing I offer to any patient with pseudomyxoma peritonei, if that's possible, if he's in a good health status and he's a good candidate for this surgery. But what if there is no chance for cytoreductive surgery? Because sometimes, as Sandra mentioned, the patient can have a very extensive disease. Patient can be devastated because he's not able to eat or to breathe properly because of the amount of mucin and tumor nodules inside of the abdomen. What if the patient has undergone multiple cytoreductive surgeries and the abdomen is full of adhesions with very hard deposits of mucin and cells joining all the viscera to each other? So maybe we can find, and we find daily many patients that are not candidates for cytoreductive surgery and PIPAC. Okay, so for example, I want to show you this picture. This is one patient. His small bowel is completely covered of mucinous nodules. He has a high-grade pseudomyxoma peritonei, and he has a very bad recurrence, and most of the nodules are covering the serosa of the small bowel. This patient is not a candidate for cytoreductive surgery. There is no chance for treatment for him by cytoreductive surgery and PIPAC. But from 2011, we have another tool, another weapon, the surgical oncologist, and we have PIPAC. I don't know if you are familiarized or not with this concept, but PIPAC is pressurized intraperitoneal aerosol chemotherapy. Basically, PIPAC is a minimal invasive technique. What we do, we just need access to the abdomen, two tiny incisions in the abdomen, less than 1 centimeter. One to place the camera, to can take a look at all the abdomen, and the other to put the capnopen. The capnopen is like a metallic port. We use this to turn the liquid chemotherapy into aerosol chemotherapy. So, and this is the name. We call this technique PIPAC. At the beginning, PIPAC was born just like a palliative technique, just for patients that they have a mass ascites, which was refractory to systemic chemotherapy, or just to relieve the symptoms of the abdominal occupation by the tumor nodules. But after treating more and more patients, we started to see that the patients, many of them, they have an impressive response to the therapy, to the combination of systemic chemotherapy and PIPAC, or just to PIPAC alone. So now we are mainly using PIPAC as a neoadjuvant therapy, just for patients with unresectable disease, with very high PCI, or with very chemo-resistant tumors. So PIPAC is like a hope for these patients, which are palliative patients in other institutions, progressing to systemic chemotherapy. In our institution, IFOCA, we have this tool, which is PIPAC. And let me show you how it works. works. So the hypothesis for PIPAC is that we are turning a big drop of liquid chemotherapy into a very, very, very small drop of aerosol. We are combining two things here, the small size of the droplets, and second, we are adding pressure. With this, we are getting an increased penetration. The chemotherapy is getting deeper into the peritoneum and into the peritoneal nodules than with HIPEC. And there is another advantage. Yes, most of the chemotherapy remains in the peritoneum and in the tumor nodules. That's why it is so effective. With HIPEC, we have this effect of the systemic passage of the chemotherapy from the peritoneal cavity to the blood. That's why after a HIPEC, most patients, they can have some side effects from a chemotherapy, just exactly the same as after a cycle of systemic chemotherapy. But keep in mind that we are using a very high dose with HIPEC, much, much higher than a cycle of systemic chemotherapy. And usually the dose that we are using of chemotherapy for PIPAC is 1/10 of the dose that we are using for HIPEC. Let me show you how it works. This is inside of the abdomen of a patient. We are in the operating room. We have already placed the ports. We are going to deliver the chemotherapy. And this metallic thing that you are seeing getting inside of the abdomen is the capnopin. This is going to turn the liquid chemotherapy into aerosol. So the administration of chemotherapy, it lasts between 3 to 6 minutes. And after that, as you can see, it's like a snowstorm of small droplets of chemotherapy. And we are using this by laparoscopy because thanks to the distribution of the pneumoperitoneum of the gas inside of the abdomen, the distribution of the droplets and the chemotherapy is very, very homogeneous. We can reach almost all the abdomen with this technique. Let me show you this. We did this in animals, and as you can see, we are not using chemotherapy now. We are using ink as a methylene blue, just to show you how homogeneous is the distribution of the liquid of the droplets of chemotherapy with this technique. As you can see, all the abdomen is stained, it's covered by this blue ink from up to down. So PIPAC is an option for this kind of patient which has a very, very extensive and aggressive disease, that we can find multiple peritoneal nodules covering most viscera or in a location that makes the patient not a candidate for cytoreductive surgery and HIPEC. This is our operating room, and I want to show you something. Here are the monitors. We are doing a laparoscopy, and this is the machine for the PIPAC. We administer the PIPAC with a high pressure injector. Nevertheless, PIPAC is a very safe technique, both for people inside the operating room and for patients. And because all the chemotherapy, or almost all the chemotherapy, remains in the peritoneum and the peritoneal nodules, the patient is not having any side effects from the chemotherapy the days after the procedure. And this is very, very important because PIPAC is very well tolerated. In fact, many of my patients, for example, for ladies undergoing systemic chemotherapy for ovarian cancer, many times they tell me, I rather PIPAC than IV chemotherapy because I feel much better. I know it's a surgery, but I don't have any side effects. They are not losing the hair, they don't feel nauseated or bad the days after the procedure. It's really, really well tolerated procedure. In many hospitals, we can even do PIPAC as a day surgery procedure. The patient comes in the morning, we do the PIPAC and leaves home in the afternoon or in the evening. Other institutions, they keep the patient for 1 or 2 days. And for me personally, it depends on the health status of the patient and the chemotherapy that I use. If I do PIPAC with oxaliplatin, I rather to keep the patient at least for 1 night because it's slightly more irritating to the peritoneum than other chemotherapies. Mm-hmm. And this is how we do it. Usually we try to combine PIPAC with systemic chemotherapy. With PIPAC, we are controlling the disease in the peritoneum. And with the systemic chemotherapy, we're trying to prevent the disease to spread in other organs and to give distant metastasis in the liver, in the lungs, whatever. So we usually make a combination of 6 cycles of systemic chemotherapy combined with 3 cycles of PIPAC. And after that, we make new evaluation of the patient just to see if the patient is finally a candidate for cytoreductive surgery and PIPAC, or we have to continue with another round of combination of systemic chemotherapy and PIPAC. What about the indications? Many times the patients, they tell me, I don't know if I am a candidate for HIPAC or for PIPAC. Well, it's totally different. So basically, HIPAC and cytoreductive surgery, this is a treatment with curative intent. We want to remove, and we are going to remove all the disease, and we are going to deliver the HIPAC, the intraperitoneal hyperthermic chemotherapy. PIPAC, on the other hand, is a minimal invasive procedure. It's just the delivery of chemotherapy inside of the abdomen with the aim of trying to reduce the disease and to make it finally resectable. But in this scenario, the patient, if we are doing PIPAC, this patient is not yet a candidate for cytoreductive surgery and HIPAC. What are the contraindications? Many times the medical oncologists, they call me from another hospital, so the patients like, I don't know if my relative, my mother is a candidate for PIPAC. Well, it's the contraindication for us is that when there is a very short life expectancy, less than 3 months. PIPAC is not a treatment for at the end stage of life. This is a moment for palliative care, for best support, for the patient, for the families, but it's not the time for PIPAC. It's slightly earlier to try to go for PIPAC. It has been classically described a contraindication for PIPAC, which is bowel obstruction. For patients that only can receive TPN, total parenteral nutrition, intravenous nutrition, or they need a permanent nasogastric tube. But saying that, I want to say that very experienced surgeons in PIPAC, we are treating patients sometimes with obstruction. And I think the most important for every patient, if you is to be evaluated by the very, very experienced team in this kind of treatment. And what about the descompensated ascites? It's not a patient with refractory ascites. We treat a lot of patients with refractory ascites with platinum-resistant refractory ascites for ovarian cancer. With patients with gastric cancer, they really benefit from PIPAC. I'm talking about patients with 7 liters, 8 liters of ascites. First of all, we have to stabilize the patient. We have to treat the systemic to deal with general status, and maybe after we can go for PIPAC. But doing PIPAC in a patient with 7-8 liters of ascites is something really, really dangerous, and most likely you will regret it if you do it. And basically, so for me, what is more interesting, and I think this is one of the most interesting slides, is what are the indications for PIPAC. So basically, it's a very promising palliative therapy in patients with isolated peritoneal metastasis when no evidence-based treatment is available. And I'm going to translate this into a sentence for no surgeons, no doctors. And again, teams that we are very experienced, we can even treat patients with, for example, liver metastasis or lung metastasis and peritoneal metastasis. But there is a very strict criteria and very, very few scenarios where we can go for this. And nevertheless, I don't recommend that kind of patients for the first cases for teams that are starting to do PIPAC. This is a situation for teams that we have done a lot of cases, and we know very well how to deal with these patients in a multidisciplinary scenario. And basically the indications, we have several drugs for PIPAC. The most used is cisplatin and doxorubicin. We use it for ovarian cancer when the patient is receiving the third line of systemic chemotherapy or beyond. The second line of chemotherapy in gastric cancer, peritoneal metastasis with gastric cancer. But saying that, there is a very interesting publication, and I will show you now later, for patients with peritoneal metastasis that they receive the first line of systemic chemotherapy and they receive PIPAC at the first time, and you will be impressed by the results. And the second line and beyond for HPP, pancreatic, liver cancer, cholangiocarcinoma. Of course, there is a very good indication, the recurrent situation in mesothelioma, peritoneal mesothelioma. Very good indication, and you will be surprised. And the medical oncologists, they really like it. When there is an intolerance to systemic chemotherapy, sometimes the patient, they cannot tolerate more systemic chemotherapy anymore, or they have a lot of side effects from the oxaliplatin in the fingers, they cannot tolerate one more single cycle of systemic chemotherapy, then we can do only PIPAC for those patients, and sometimes it works very, very well. The same when there is an important deterioration of the quality of life with the systemic chemotherapy, PIPAC has a very important role to play for these patients. And as I mentioned before, the ascites in the platinum-resistant situation is an important indication for PIPAC with cisplatin and doxorubicin. We can use as well PIPAC with oxaliplatin, basically for colorectal cancer, peritoneal metastases, and another indications, or when there is a contraindication to use cisplatin and doxorubicin, we can use another drugs for PIPAC and the new taxanes and many other drugs. And we really want to prevent and to avoid the same situation, the same scenario that we can find in HIPEC, that every hospital in the world is using a different protocol for HIPEC with different duration of the treatment, with a different carrier for the drug. It's very difficult to get evidence and to get information if every one of us, we are doing a different thing. So with that aim, we published last year in the European Journals of Clinical Oncology our consensus for technical aspects and treatment protocols for PIPAC. We really want and we encourage all surgeons doing PIPAC around the world to use our protocols because this is the way to create evidence very, very fast, and this is very good for the patients. So more than an evolution in peritoneal disease, PIPAC has been a true revolution. It's not something that appeared yesterday. It's been 20 years of work by Professor Marc Remond. Wow. And yeah, and the most revolutionary, a lot of years of developing the device, after that testing the animal models. So it's been a long way. And it really, the most revolutionary is that it really induces response in chemo-resistant peritoneal metastasis. And what about the evidence? Well, I want to show you the publication in one of the most, I can say, the top 3 journals about surgical oncology and oncology in the world, which is the Lancet Oncology. So this is the publication of the first 1,800 PIPAC procedures. We did for 838 patients. The most important is that it was proven that PIPAC is feasible. It's feasible to repeat PIPAC in more than 65% of the patient. I think that with our experience now, it's even higher. And the most important, and those are very impressive data, is that we got response, clinical response for patients up to 88% of patients with ovarian cancer, 91% of patients with gastric cancer, 86% of patients with colorectal cancer, and 75% of patients with peritoneal mesothelioma. And this is very impressive because those are patients which are receiving second or third line of systemic chemotherapy. The disease keeps progressing to systemic chemotherapy, but when we are delivering the chemotherapy by PIPAC, they are responding to the treatment. This is part of the experience of PIPAC and pseudomyxoma peritonei and appendiceal cancer. I want to show you here, I'm sorry for the photographs, you're really sensitive, but I think it's really worth it to take a look. These are the kind of peritoneal nodules I was explaining to you before. For those patients with a high-grade pseudomyxoma peritonei recurrence or a high-grade pseudomyxoma peritonei or an appendiceal cancer and carcinoma from the appendix with mucinous component, you can find this kind of peritoneal nodules. They are really pearly white and filled with mucin, but they are very, very hard. So here you can see that there are multiple peritoneal nodules covering the viscera. This is part of the bowel and the diaphragms. And I can show you here now the same area after repeated treatment with PIPAC. And you can see how many nodules have disappeared, or they are now really, really flat. They are not anymore like a nodule, but they look much more like a scar, like a flat scar at the peritoneum. What if the patient is not even responding to PIPAC? Well, we have another tool, which is ePIPAC. And PIPAC is like PIPAC, we are adding an electrostatic precipitation to the chemotherapy. So we chart the chemotherapy and the air in the side of the abdomen, and we apply a discharge to the patient. The patient is not feeling anything at all. We just do that to attract the chemotherapy deeper inside of the peritoneal nodules. One of the promises of this technique is that we can increase penetration 4 times compared to PIPAC. So it's a promising technique. Still, we are doing a lot of tests, and we can offer it outside clinical trials, but again, in very experienced centers. And I want to show you some of the results of this technique, and it's truly, truly impressive. As you can see, the response, this is a very aggressive, this is for patients with pancreatic cancer and very aggressive cancer of the appendix. And as you can see at the beginning of the treatment, for this patient, their right hypochondrium was completely covered of more than nodules. It was all a plaque of peritoneal disease. And this is after the 1E PIPAC, and this is after PIPAC. I want to show you something about the results and how powerful PIPAC can be for patients. And here is the situation of the survival data for patients with peritoneal metastasis of gastric origin from stomach cancer. And as you can see, this is the survival for the first line, second line, third line of systemic chemotherapy. This is the survival for patients undergoing cytoreductive surgery and HIPEC. I'm talking about patients who are candidates for cytoreductive surgery and HIPEC. And I want to show you one of our last publications, and this has been totally revolution because it has never been reported before in the history, this survival for this group of patients, PIPAC plus chemo upfront. Patient is receiving chemotherapy plus PIPAC, and we are getting the same survival, even better than with cytoreductive surgery and HIPEC. So this is really, really impressive. How many of our patients receiving PIPAC are finally candidates for cytoreductive surgery and HIPEC? I guess most of you are wondering. Well, it's about 15% of our patients, and for certain diseases, around 20% of our patients, they can finally undergo a cytoreductive surgery and HIPEC. But for many patients, PIPAC becomes like a chronic treatment. That means we are not getting to a point that we can do cytoreductive surgery and HIPEC, but we have stopped the progression of the disease. The patient is just coming to receive the PIPAC, the disease is stable, so more or less it's like a chronic disease, and the patient can have a very good quality of life receiving PIPAC after PIPAC. So as I told you, quality of life is very good with this treatment. It's as a diagnostic laparoscopy, patient is not feeling absolutely, it's very well tolerated procedure, even for very elderly patients. And we have a lot of evidence on that about the quality of life. PIPAC had absolutely no negative impact on peritoneal malignancy patients, quite the opposite. Many of the patients, they start to feel better, to eat better, and can get much more to a normal life, what normal life was for them before the diagnosis of peritoneal disease. And this is our publication for Nature last year. This was a very important review we did about all the treatments available for peritoneal surface malignancy patients. And this is the first time that PIPAC has been incorporated to the protocols and to the treatment schemas for sequences for patients with peritoneal metastasis at any disease, even for patients with pseudomyxoma peritonei or appendiceal cancer. And this is very important because with this, we want to spread the knowledge, we want to spread the message to medical oncologists. This is Nature, this is a journal not for surgeons, this is a journal for all physicians, all caregivers. We want to spread the knowledge about when is the time to go for PIPAC, what is the power of PIPAC, and what patients can benefit from PIPAC. Not any surgeon doing cytoreductive surgery in HIPAC can do PIPAC, and if they want to get the certification to can do PIPAC, they must come to be trained with us, and then I or one of the other international trainers, we even travel to different countries to assist the surgeons during the first procedures. For example, here I am with the team, with one team in Spain. Here we are part of the international trainers with Dr. Mohamed Al-Yami, Clarisse Beno, Olivia Scarborough, Martin Hubner, and I. We have trained, I don't know how many surgeons, how many countries. Our next course will be held in Israel in September. And Martin Hubner, Olivia, and I, we are traveling to Tel Aviv to train surgeons in the Middle East, and so more patients there can benefit from PIPAC. So in conclusion, I just want to emphasize that PIPAC for the treatment of pseudomyxoma peritonei and appendiceal cancer is a very good indication for patients with high-grade pseudomyxoma peritonei or peritoneal metastasis from adenocarcinoma or manic from the appendix or globate cell carcinoma. What is the issue for low-grade pseudomyxoma patients? Well, keep in mind that we are giving chemotherapy. And if there is no cells, there is not a big rationale for chemotherapy only, but nevertheless, HIPAC, we are doing HIPAC for patients with low-grade pseudomyxoma peritonei recurrence. So basically, it depends on the location and the situation. BROMAC, that next week or in a few days, my friend Alvaro Jona, he will talk about the BROMAC treatment, the bromelain and acetylcysteine, which is a mucolytic to solve the mucin. Has another indication is for a more located recurrence, but for high grade, this works very, very well, patients. For patients with non-resectable disease, keep in mind that this is a minimal invasive disease. It's very, very well tolerated. You will be home that night or the day after the procedure. You will see how well you can keep your quality of life, and even it will get improved. And my advice, as always, please always look for a certified surgeon. Only certified surgeons who can perform PIPAC, and look always for experienced team. In our oncological institute, we receive patients not only from Spain, but from around the world. They travel to Madrid, and we have a program to help them travel and to assist them with all the issues regarding the trip. And that's all. Thank you again, Sandra, for the invitation and for the opportunity to share about what PIPAC can do for patients with appendiceal cancer and pseudomyxoma peritonei. Here is my email, my contact in social media. Open now for any question and discussion. And of course, if you want, you can reach me in social media too. Thank you, Sandra.
Thank you very much, Dr. Cortés. I think it's very exciting to learn about PIPAC and about the promising results that we can get with this technique, mostly for patients that have been denied the treatment with HIPAC and that they can only reach kind of palliative treatments at the moment, and there's another way to improve their quality of life with a technique that it's not as aggressive as HIPAC, or even not as aggressive as systemic chemotherapy. And also we've seen that some patients can also, even after a few sessions with PIPAC, be eligible to have a curative treatment with HIPAC. So that this is very, very promising. And thank you very much, Dr. Cortés, to you and to all the team that is working and improving the techniques to find a cure for pseudomyxoma peritonei and appendix cancer. So for all of you who want to ask questions, you can do it with the little sections down here with questions and answers. You can do it or through the chat, and we will be forward like reading your questions to Dr. Cortés. So I can see, okay, we have a couple of congratulations. I hope Sergio Guillermo Casillas, that you could finally see the slides. And congratulations from Brazil. Si alguien quiere hacer preguntas en español, también podéis hacerlo en la sección de preguntas y respuestas o en el chat. Meanwhile, I would like to ask you a couple of things. First thing, as I understand, PIPAC basically uses pressure the same way that HIPEC use heat.
Yes, exactly. So with HIPEC, we are using heat to try to increase the effect of the chemotherapy. PIPAC is normothermic. The chemotherapy is not heated, it's about room temperature. But we are using the pressure of the laparoscopy to try to make these small, very small droplets of chemotherapy get deeper inside the peritoneal nodules.
And also, is the same type of drug, the same type of chemotherapy that you use in PIPAC and in HIPEC, or are different?
Yes, we are using the same kind of drugs. Cisplatin and doxorubicin has been used worldwide for HIPEC for many years, as well as oxaliplatin. We can do PIPAC with mitomycin as well. We can do PIPAC with gemcitabine, which is for pancreatic cancer, for example. And we can do PIPAC with Abraxane. There is a very nice publication from the group of the Dr. Wim Salim about the new and the safe dose of Abraxane, and it's very exciting. It has been very promising for all of us because now we can use it safely at a very good dose. We are doing many trials in the world just to try to see if we can increase the dose of PIPAC, because we started with very low doses. We really wanted it to be a very safe technique for the patients. And now, for example, Manuela Rovella from Italy, she conducted a good trial on oxaliplatin, and thanks to that study, we have increased our dose of oxaliplatin from 90 milligrams per square meter to 120 milligrams per square meter. So we are not static. We are doing a lot of research and a lot of trials for PIPAC patients.
Okay. And another question before moving forward to all the questions that the participants have is if during the PIPAC, do you do cytoreductive surgery as well, or when you do PIPAC, you only do PIPAC? I'm not sure if I'm being very clear with my question.
And it has been our question for years. We said, no, if we're doing PIPAC, we cannot do anything else for the patient. So last year it finished one trial and they combined multiple procedures with PIPAC, multiple surgical procedures with PIPAC, as well as there is one ongoing trial. They are doing gastrectomy, the lymphadenectomy, gastrectomy with curative intent for gastric cancer, and they are doing PIPAC at the same time. So yes, we can do some procedures. For example, sometimes we do a stoma and we do PIPAC, or for patients with a very bulky omentum, sometimes we have removed the omentum so patient can eat and feel better, and then we proceed for PIPAC. Yes, we can combine PIPAC with surgical procedures.
Okay, great. So let's have a look to your question. Okay, Declare, is this procedure valid for LAM without systemic chemo?
Okay, so for LAM, which is low-grade mucinous neoplasm of the appendix, you are not going to receive systemic chemotherapy, basically. So as I mentioned before, the first, if you are a candidate for cytoreductive surgery and HIPEC, and you are using chemo, and it's a low-grade mucinous neoplasm, you are using chemo and heated chemo, yes, you can go for cytoreductive surgery and HIPEC. What if the recurrences or the pseudomyxoma at the beginning is very, very bad, and you are not in a very good healthy status? You can try to go for it. Nevertheless, keep in mind that there are another treatments too, like Bromac, that if you have 1 or 2 or 3 isolated focused recurrence or location of the tumor that make the disease not resectable for LAM, probably Bromac is a good alternative. If you have a very extensive disease covering extensive areas of the abdomen, sometimes PIPAC is a good chance, but it works better for high-grade pseudomyxoma peritonei.
Okay, another question. Can you add additional comments about the first-line chemo type dosages? Can you add additional comments about first-line chemo type doses?
Well, yes, of course. Well, it depends. I mean, if you are going, I guess that Guillermo is talking about gastric cancer. So we are talking about the FLOT protocol, which is the worldwide now the gold standard for first-line systemic chemotherapy for gastric cancer, combined with PIPAC. And we usually you can do either for gastric. You can do oxaliplatin PIPAC, or you can do cisplatin and doxorubicin PIPAC. If the patient has ascites, we do recommend to go for cisplatin and doxorubicin, because the doxorubicin has an sclerosant effect on the peritoneum. It's very, very good to control the ascites.
Okay. Okay. So declare with unresectable areas. He also asked about the LAM. Okay.
Yes, unresectable areas of the abdomen. Yes, because sometimes we speak like it's super obvious for everyone. Well, unresectable areas are, of course, when the photograph I show you with all the small bowel serosa cover of nodules. The small bowel serosa, if it's massively affected, this is considered non-resectable disease, because you cannot live without your small bowel. Well, if you are into the field of pseudomyxoma, you know that a small bowel transplantation is one of the options for end-stage pseudomyxoma and very aggressive pseudomyxoma peritonei. Another area is, for example, at the liver pediculum, or at the very root of the vessels. Those are the unresectable areas that if there is a lot of disease there, you cannot remove the major vessels of the abdomen. You cannot remove the superior mesenteric artery, the celiac trunk. If there is a massive involvement of that areas, this unfortunately makes the disease unresectable.
Okay. Next question, Amy. In the United States, PIPAC is currently offered as a trial only. Do you know if the US offers PIPAC in their trials?
Thank you, Amy, for your questions. I have treated many patients from the United States here in Madrid because of this issue, because they were not eligible for the active clinical trials. So they just came to us, and we're doing PIPAC here for them. To my knowledge, there is no active PIPAC trial in United States. But if you want to, I can, because these things can change from one day to another. If you want to email me or to go to the ISSPP webpage, we try to keep our information regarding trials very updated. So you can have their more accurate information, or if you want to email me, I can get in touch rapidly with my friends doing PIPAC in the United States, and I will get back to you with the information. But I don't think so. I don't think they are doing any PIPAC trial. I think it's in Europe where we are doing those trials.
Okay. Next question, Marianne. We have been hearing about some innovations in doing multivisceral transplant to treat PMP, primarily done in England, first one done in the US 10 months ago. Could PIPAC be used to either help prepare a patient for a multivisceral transplant to reduce the tumor burden, or B, after a transplant to try to eliminate remaining cancer cells that could result in a recurrence. The later issue would primarily be a challenge for people with high-grade cancers. And also, well, let's go for this first question first.
Yes. So first thing first. So I have just mentioned that multivisceral transplantation for PMP, it's at the very end stage surgery when there is absolutely no other option. It was developed basically in basic stock, and they have the biggest experience in the world doing that, the team in basic stock, with my very dear friend Brendan Morander and the rest of the team. Saying that, yes, probably some of these patients, there is a new hope and a new alternative, especially for patients with high-grade pseudomyxoma peritonei. There is an option, you can give it a try to PIPAC. At the end, you always have the option of transplantation, which is much, much more aggressive than going for cycles of PIPAC. And if at the end, the disease is responding, or we can keep it stable. I want to give you an example of one patient. She is a patient with ovarian cancer. Lovely. She has received, I think the last time they said it was 23 PIPAC.
Wow.
And the disease is not disappearing, but it's not progressing. And she is alive now for years. And she was a palliative patient when she started the chemotherapy, the treatment with PIPAC. She had no other options. Medical oncologist already told her, goodbye. No, there is nothing we can offer you. So for sure, for these patients, especially in the scenario of a high-grade pseudomyxoma peritonei, giving it a try to PIPAC is a very good option. Keep in mind that multivisceral transplantation, of course, is the most extreme option, therapeutic option a patient can be offered. And of course, as we have seen, you have the issues of the immunosuppression after transplant and other issues. So yes, why not? You can give it a try, 2, 3, 6 cycles of PIPAC. If it's not working, you can still go for the transplantation. And if it's working, maybe you would rather to go every month or every 6 weeks for a PIPAC instead of having a transplantation. This is so important, I think, always, that we have to let the patients take the decision. And we have to be very honest to put crystal clear all the options on the table. And the patient, of course, we are there to advise and to give our opinion, but at the end is the patient who has to take the decision. It's the patient's life. So
yeah, true. So she also has a second question, a general question. Once cancer has penetrated the small bowel beyond the surface, is PIPAC or other forms of chemotherapy effective?
Okay, let me explain you one very technical detail about PIPAC. And the reason why systemic chemotherapy does not work usually for peritoneal disease. And the issue is that all our blood, let's say that we have our cardiac output, and only 3 to 6% of it reaches the peritoneum. So you can overload your blood with systemic chemotherapy, with a high dose, a very aggressive molecule, giving you a lot of side effects, killing a lot of cells in your healthy cells in your body. This is why it causes side effects most of the time. And you cannot have a response in the peritoneum. The tumor cells in the peritoneum, they can keep growing, because, and especially in the case of mucinous tumors, because now we know a lot about the microenvironment of mucinous tumors and how they protect themselves from chemotherapy. So very few amount of chemotherapy, systemic chemotherapy, really reaches the peritoneal and the tumor nodules and the peritoneum itself. What is, on the other hand, why we, using such a small amount of chemotherapy, such a small dose of chemotherapy, are getting such a huge effect with PIPAC? Because all the chemotherapy stays just in the peritoneum. We want it to go to the peritoneum. We don't want it to go to the blood. We don't want it to go to your brain, to your stomach, to your kidneys, to your liver, to cause side effects, to your bone marrow. So you their leukopenia, anemia, plaquetopenia. We want it to stay in the peritoneum. It has to stay and to make action into the peritoneum and the tumor nodules. And the reason is that with this small size and with this pressure, we are really succeeding in keeping the chemotherapy in the tumor nodules. That's why it's so effective with such a small amount of chemotherapy.
Yeah. I think it's also very interesting that this treatment, it's not damaging the quality of life of the patient. So you can also, you know, continue with your life and have a good quality of life, because sometimes we focus a lot on the treatment to do it fast, to do it quick, to go for it. But sometimes the cost is the quality of life of the patients and the side effects of these treatments.
Yeah, exactly. And at the end, keep in mind, for example, PIPAC is very, very good to the ascites. I think one of the things that for peritoneal surface malignancy patients that really, really worsen the quality of life is the ascites or the mucinous occupation of the abdomen. Patient cannot breathe properly, the diaphragm goes up. Patient cannot eat properly because all the small bowel is compressed by the ascites or the mucin. So when we treat this and when we control that, quality of life improves dramatically. It's impressive, and it's very good to see the patients benefiting that way from PIPAC.
In case of recurrence after HIPEC, would you go, if the patient is eligible for a second HIPEC, would you go for a second HIPEC, or would you try PIPAC instead?
No, if the patient after pseudomyxoma peritonei, if the patient is eligible for surgery, I would do cytoreductive surgery and HIPEC 100%.
Even if it's a recurrence?
Yeah, sure. Yes. Yes. I have a lot of experience with iterative HIPEC for recurrence, and it's in this scenario, it's good to go for it. But you have to be 100% sure you can remove every single tumor nodule. Otherwise, I would start with other strategies like PIPAC or BROMAC or whatever. But if it's a pseudomyxoma, but if it's resectable and the patient is in a good health status, because many times after first HIPEC, sometimes a patient, it takes time to recover and to get back to their normal quality of life. We had a talk about that a few weeks ago with you and other patients, and it's what it really touches my heart that many teams, they are not treating the patients like a whole, and they are just doing the surgery and we have to deal with everything, the physical recovery, respiratory recovery, nutritional recovery, everything. We cannot just do a perfect surgery and leave the patient as go home. Good luck for the next 4 months to get back to your baseline status.
Yeah, that's I was trying to answer to the Clara also question here. He says he has recurrence and that he's healthy. So that's why I was asking, in case of recurrence, if the patient is healthy, feels okay, would you go for second HIPEC? Or
it really depends. A healthy patient with a recurrence of low-grade pseudomyxoma, completely resectable, 100%, I would go for cytoreductive surgery and HIPEC. For low-grade, I would be very careful about I would be very, very sure that I can resect absolutely everything. Otherwise, I would start with another strategies. And with a recurrence, which is not resectable, you have to define another strategies. You cannot even think about HIPEC or cytoreductive surgery. You have to start for PIPAC, which is, we do it a lot. It's very common. Patients will come to us with a non-resectable recurrence, and then we have to start with PIPAC or another strategies.
Okay, so Guillermo asked for cost of the infrastructure. I don't know, maybe that's something that you can discuss some other moment. And Marianne, do you know why PIPAC has not been officially approved in the US for broader use?
I think it has been mainly because some requirements of the device. You know that in the United States, the legislation to bring new devices in, it was an entirely Europe developed device. And it took, yeah, that's life. And it took a long time to get the approval from. And keep in mind, we are combining three things here. We are combining a high pressure injector, which is a device off-label for chemotherapy. The use is for contrast, for vascular intervention, or for radiologists. So we are using this first device off-label. Second, we are using the capnopen, which is a European approved and developed device. And third, we are combining it with intraperitoneal chemotherapy, which in most of the indications and the technical description of the chemotherapy is off use, is off label. The people is the FDA is not recommending the use of chemotherapy for direct intraperitoneal administration. So yes, it took long time to can get PIPAC into the United States. And it's true that in most of the scenarios, it's only approved in the clinical trial setting.
Okay. But mostly in Europe, it's possible to find expert teams doing PIPAC. Let's say, obviously, France, UK, Netherlands, Germany. I'm not sure how many countries in Europe are using PIPAC at the moment. Please, you know.
I think in Europe it's really widespread. I think in Europe you can PIPAC treatment at almost every single country, to my knowledge. We are spreading it now in Middle East, which is common. In fact, the hospital I've been worked in Saudi Arabia, we have been the only center doing PIPAC for all Saudi Arabia for 3 years. But now they are starting in other centers because we did 2 courses of PIPAC to train other surgeons. And in the United States, it's the same. In South America, I have a lot of consultations and from patients from South America, from different countries, because they face, it's very difficult for them. It's very, very difficult to.
If anybody from any country can find information about if there's any expert team doing PIPAC, they can contact us or they can contact Dr. Cortés, and we can find this information for you. See if you have the option to do this treatment in your country.
Exactly. I think every week I have consultations from patients from around the world, from Brazil, from many countries, like, is there any doctor here doing it? Who do you recommend? Things like this.
Yes. But again, like for us, it's so important. And also this month of August that we are trying to bring awareness to pseudomyxoma, peritonei, and appendix cancer. It's so important to spread information among, patients and among caregivers about the options that they have, and to learn more about this disease and to learn more about the treatments, and always to try to find, some hope or to improve the quality of life of the patient. So we, like our team here in Spain, Dr. Cortés, or any of the organizations that are working in this special awareness months, PMP survival, PMP pass. You can contact them and we will find the information for you about the closest PIPAC center for you. Let's see if we have any more questions. The Clark City of Hope is doing PIPAC Duarte, USA. Okay.
Mount Sinai, they are doing PIPAC, but most of the cases for in the clinical trial setting so far.
Okay, Marianne, another question. Just a huge thanks for the work that you do and for being so open to answering our questions, sharing your email, etc. You're definitely giving us hope.
Thank you, Marianne. Thank you. And as Sandra, I'm always keen to talk to anyone, or if I'm super busy, my secretary. But and it is that I always try to be open and to be accessible, because there is a lot of lack of information. And as I was spoken to Sandra before we started this Zoom meeting, what really breaks my heart is when patients, they have to find for us themselves, because the physicians, they are not referring them. It's very hard way for them. And when they get to us, many times we have lost the chance, the window of opportunity to treat them. So as Sandra mentioned, the more we can spread the knowledge about the indications and the benefits of PIPAC, I think many patients around the world will benefit from it. So.
And it's so hard for the patients when you are told that there's nothing else that the doctors can do for you. Sometimes we find that when a patient receives this message, it's like they give up.
Exactly. Yes.
They give up. And even if there are some other options that they don't know, but once they hear this, that, you know, they give up. And it's so hard to see. It's so hard to learn that, because someone has told them that there's nothing else that is possible to do, that the patient has just decided to give up. And it's probably the family, the friends around them that are pushing to. And I would say that, at least for us, probably 60% of the people that contact us is not the patient itself. It's family, friends that are trying to go forward to find options.
Yeah, it happens to me all the time. It's like, my sister has just been diagnosed with that, and we are not sure, because at the hospital they are doing only cytoreductive in PIPAC, and they told us there is no more options, but we have heard about you, social media, I don't know, whatever, and many times it's true that it's the family or the relatives or friends who are trying to get to you, like my friend or has been said that there is no more options, but I have heard that there is something beyond cytoreductive Syrian PIPAC. So that you are not doing this in your hospital is not a reason to tell the patient this is the end of the road. This is not.
I think that this is the most important message also for today. All that you have, all the information that you have shared with us, and that we must always look for a light at the end of the road, and there's always something that we can try. And a no is not always a definite no. Maybe you just need to try. Maybe you just need to keep on asking.
Of course. When there is life, there is hope. So just look for the look for the experts. Look for units with multiple options of treatment, and be evaluated by a tumor board with a huge experience in the treatment of peritoneal surface malignancies, with innovative techniques, with active clinical trials. That's my advice.
We have another question also here asking if PIPAC is currently approved as a treatment in Canada.
Next question. I'm not 100% sure, Amy, but again, if you send me an email, I will try to find the answer for you, and I will try to, if there is an active team, I will get you in touch with them.
Okay, so we are going to start finishing the session for today. I don't know if there's any question. ¿Alguna pregunta en español? ¿Alguien que quiera preguntar en castellano? Otherwise, I don't want to steal more of your time, Delia, because I know you're very, very busy always, and you are so generous to share your time with us and to help to bring awareness and to bring light about this improvements on treatments for PMP, on appendix cancer, and also for other types of cancers that can benefit from PIPAC.
That's my passion. That's nothing makes me more happy than spread awareness and that patients with peritoneal surface malignancies can get the best treatment around the world, and keep researching on this disease to give new hope every time to our patients. So this is my passion. I'm very happy doing this. Thank you.
Thank you very much, Dr. Cortés. Thank you very much to all of you for joining us today in this session. Next week, we will have another session about BROMAC on next Thursday, 25th. So we hope to see you all there as well. So thank you very much.
Thank you everyone for joining.
Thank you. Thank you. Goodbye.